So I'm Rosanna Hill and I'm going to do a light bite on genitourinary symptom management. So we'll talk through bladder anatomy and physiology, the autonomic innervation of the bladder, drugs affecting bladder function, and then we'll talk through bladder symptoms and the different causes and management options. So if we initially look at this diagram of the bladder, so on the left you've got the male bladder anatomy and on the right you've got the female. So the important parts to notice here are the detrusor muscles, that's the bladder wall, and that has important roles to play in different bladder symptoms that we see. And also you've then got the external sphincter down here, which sits in the urethra, that's present in both males and females. Then you'll notice an important difference. So at the bladder neck here, males have got an internal bladder sphincter just above the prostate, which is not present in females. So in terms of the sort of nervous system innervation of the bladder, it's important to remember you pee with your parasympathetics, you stop with your sympathetics, and that's quite a useful way of working out how the different medications can affect bladder control. And it's also important to know that when the bladder sphincter relaxes, so that's the bladder neck sphincter that's present in men, when that relaxes, the bladder muscle contracts and vice versa. So they both do the opposite. And that makes sense because in order for you to pass urine, you'd need the bladder muscle wall to contract to try and force urine out, and the bladder sphincter would need to relax to allow the passage of urine. So they have the opposite effects at the same time. The urethral sphincter, which is the external sphincter we just mentioned, that's present in both males and females, is an additional voluntary mechanism, and that's innervated separately by the pudendal nerve. So here's the same diagram, but in a bit more detail. And this is probably the most important bit to be able to understand. And if you can think about where the different receptors are, that helps you to work out when patients have got different symptoms, how those different medications can affect bladder function. So if you look initially, you've got the parasympathetic nervous system coming in here via the pelvic nerve. And if you remember, you pee with your parasympathetics. So that acts on the muscarinic receptor here via acetylcholine. And the parasympathetic causes contraction of that detrusor muscle, which helps pass urine, so hence you pee with your parasympathetics. And the fact that it acts on the muscarinic receptor here to cause that bladder muscle spasm also explains why antimuscarinics have such an effect on bladder function. So if we give, for example, an antimuscarinic for a different reason, such as giving amitriptyline for pain, we can relax, this can cause relaxation of that bladder muscle, and that's why you can get urinary retention with drugs such as amitriptyline. It also explains why you can use amitriptyline or other antimuscarinics like oxybutynin to help with symptoms like incontinence or bladder spasms, because you want to relax that detrusor muscle because it's overactive. Now, if you then move on to look at the sympathetic nervous system, so remember you stop with your sympathetics, that acts again on the detrusor muscle, but this time via noradrenaline and the beta-3 receptor. And if you look, that has the opposite effect. The beta-3 receptor and noradrenaline causes relaxation of the detrusor muscle. And the beta-3 receptor is important for us because it's where mirabegron acts. So mirabegron is a beta-3 agonist. So that causes relaxation of that detrusor muscle. The difference being it works in the same way as antimuscarinics, but it can be useful in patients such as the elderly or those that you're worried about antimuscarinic side effects. Because it acts on a completely different receptor, it doesn't have all the antimuscarinic side effects that we can often worry about. And also the sympathetic nervous system here acts on the alpha-1 receptor on the internal sphincter that's present there in males. Now, you might recognise drugs like tamsulosin or alpha blockers. So they block the contraction there of the internal sphincter. So they can be useful in things like prostatic hypertrophy, where the internal sphincter often is too contracted, and you can have problems with hesitancy and poor flow. So alpha blockers help relax that internal sphincter and can help the passage of urine. And then this is just showing the pudendal nerve acting on the external sphincter, which we'll talk less about. So just to go through those really in a bit more detail. So as we know, there are various drugs that affect bladder function. So we talked about tamsulosin, which is an alpha blocker, and that acts on that bladder neck sphincter, which is only present in men. Antimuscarinics such as oxybutynin relax the detrusor muscle. And we talked about how the relaxation of the detrusor muscle coexists with contraction of that bladder neck sphincter. Opioids can have quite a big effect on bladder function, which I hadn't really appreciated. So you can get reduced bladder sensation, you can get increased sphincter tone increased, but you can also get the detrusor muscle tone increased. So opioids can cause either hesitancy or bladder spasms. They can also cause retention. So they can cause both effects. Tamsulosin, as we said, is an alpha blocker, so it's used in benign prostatic hypertrophy. It can be used in urethritis. It's often used before a trial without catheter for patients or for men that have had acute urinary retention. It can't be used if someone's got symptomatic postural hypotension. And there is a risk of severe hypotension resulting in hospital admission in those first 4 weeks. It's metabolized by cytochrome P450 enzymes, so it can be affected by enzyme inhibitors or inducers, and the absorption is significantly affected by food, so it should be taken at the same time every day. Oxybutynin, as we know, it's an antimuscarinic. Now we use other antimuscarinics like amitriptyline, but they're less selective. Oxybutynin is relatively selective for M1 and M3. Now M3 is really important for bladder function, so it's a really good antimuscarinic because it's more selective for the bladder function. Problem is M1 has a role in cognitive function. This is why oxybutynin can also have side effects on cognition and cause confusion. So solifenacin and festeridine are other antimuscarinics that are more selective for M3. So they tend to be more tolerated and don't have as much effect on cognitive function. But oxybutynin is first line still due to cost. So just a bit of a recap on antimuscarinic side effects. So they can cause all sorts of side effects. So CNS effects, they can cause drowsiness, cognitive impairment, delirium, agitation. They can cause problems with visual impairments. They can cause blurred vision. They can cause cardiac side effects, so tachycardia and palpitations and arrhythmias. The most common one we see is the GI side effects, a dry mouth, but they can also cause heartburn and constipation. We've mentioned that it's got urinary side effects. It can cause hesitancy or urinary retention, but because of this, it can be very useful for bladder spasms and urinary incontinence. And they've got skin effects. They can cause either reduced sweating or flushing. So in terms of bladder spasms that we might see, we see two opposite problems, if you like. We see the first one where you get frequency or urgency, urge incontinence and bladder spasms, which are all caused by an overactivity of that detrusor or the bladder muscle. Or you can get the opposite problem where you get difficulty voiding with hesitancy or slow stream or urinary retention, which is either due to the contraction of that bladder neck sphincter or the relaxation of the bladder muscle wall. So we'll talk a little bit about frequency and urgency. So there's lots of causes. It can be related to cancer itself, so you can get bladder spasms that cause these symptoms. You can get mechanical irritation from cancer itself, hypercalcemia, pain, and sacral plexopathy, so problems with the nerves and nerve compression. Treatment itself can cause symptoms, so drugs such as cyclophosphamide, if they've had that as a chemotherapy agent, or diuretics, or from radiation cystitis. It's important to think about infections that would need excluding in these patients. And they may also have other neurological disease that can cause urinary frequency, such as dementia, post-stroke, MS. And then there's diabetes as well. So it's important in terms of urge incontinence, you can have urgency without incontinence, but the problem is we need to limit delayed voiding. So patients might have urge incontinence because of weakness and difficulty getting to the toilet. They might not be as interested in trying to get up, so depression may be a feature. They might have lack of awareness of when they need to go to the toilet, so due to confusion or drowsiness. And then they may have urinary retention with overflow. They could have genuine stress incontinence. So the management of this would be to correct anything that's correctable. So any drugs such as diuretics, for example, treat a urinary tract infection, hypercalcemia or diabetes. And then you've got non-drug treatment. So trying to encourage people to go to the toilet often, making sure they've got good access to the toilet, such as a commode or a urinary bottle. And as much as possible, rapid response from staff on the ward, which I appreciate can be difficult at times. And then avoiding excess fluids, alcohol or caffeine. So in terms of drug treatment, so urinary incontinence, urgency, frequency, they're usually due to the fact that, as we mentioned, the bladder muscles, the detrusor, is overactive. So what we want to try and do is relax that muscle. So to relax that muscle, we can either use antimuscarinics. So as we mentioned, oxybutynin is usually first line, or there's other antimuscarinics, but it may take 4 weeks to see a response. You can also think about the beta agonist and mirabegron, beta-3 agonist, and that's useful if the antimuscarinics are contraindicated or if they're not tolerated very well. Other options, you can think about tea-time dose of furosemide, and that can be really helpful for people that have got persistent nocturia. So in terms of bladder spasms, the definition of these is a transient, often excruciating sensation in the suprapubic region, and it's due to irritation of the bladder muscle. Again, in our patients, it can be due to the cancer. It can be either irritation of the cancer itself or side effect of radiation that they've had. And there's also other causes, so anxiety, infection. They may have a catheter that's causing irritation. So in terms of managing bladder spasms, have a think about any reversible causes. So if they've got a catheter in, could we change the catheter, see if we can reduce the balloon volume? Have they got catheter sludging? So think about bladder washouts, encouraging oral fluids or irrigation. If they've got hematuria, again, treat any infection, think about tranexamic acid. Or if they've got infection, treat with antibiotics and oral fluids, and think about bladder washouts and changing the catheter. If we are going to think about drug treatment, then again, we're talking about antimuscarinics because that's going to relax the bladder muscle wall. So you can think about the relatively selective ones like oxybutynin or tolterodine, or the less selective antimuscarinics that we often use, such as amitriptyline. You can give treatments directly into the bladder. So if you've got a catheter in place, you could think about giving morphine or bupivacaine, which is a local anaesthetic, directly into the bladder via the catheter, and that can be quite useful. So the opposite problem we mentioned is voiding difficulties, and that would normally be hesitancy or a slow stream or terminal dribbling. And that's also got multiple causes, especially in our patients. So it could be cancer related, and that would usually be things like cauda equina syndrome or nerve root compression. There may be infiltration of the cancer into the bladder neck. They could have a malignant enlargement of the prostate. It could be medications that we're giving. So we talked about antimuscarinics can be useful for things like bladder spasms, but actually they can cause problems themselves. So if they relax that detrusor muscle, you can get problems voiding and passing urine. So antimuscarinics can be problematic. Also things like intrathecal nerve blocks or morphine, as we mentioned earlier, or spinal analgesia. Other causes are generalized weakness, constipation, or they may have benign prostatic hypertrophy, BPH. And again, we like to think about non-drug management first. So if they're in acute retention, they need to be catheterized, and then to try other mechanisms if possible. So making sure they've got privacy, trying to get them to stand if possible, use things like running water, a warm bath. And if those aren't possible, then we might need to think about catheterization. So in terms of preventing this for the future, particularly tamsulosin is the one we see most commonly, and you see the benefit of tamsulosin in days. And as you remember from that picture we saw, tamsulosin acts here as an alpha blocker and helps to relax the internal sphincter, which helps the passage of urine. Another option would be finasteride, which would be less useful in our patient population because the benefit takes 3 to 6 months. So the last bit is just to briefly mention about catheter care. So indications for catheterization would be acute urinary retention, impaired bladder emptying, urinary incontinence, or we sometimes use it for management of symptoms provoked by voiding. So if patients got significant pain on movement, we want to try and limit how much they're having to get up out of bed, for example. So some general principles. So it's really common to get bacterial colonization, so 30% by day 7 and almost 100% by day 28, which is why it's not that useful to look at a CSU because they're likely to be positive. And a UTI in patients that are catheterized are more likely to present with non-specific symptoms. And a urine dipstick is unreliable. So if you think someone has got a UTI, then it's useful to send a culture but start empirical treatment. Changing a long-term catheter before starting antibiotics improves treatment rates for UTIs. And continuous prophylaxis against a UTI is not currently recommended. So in summary, you pee with your parasympathetics, you stop with your sympathetics. It's useful to think about the receptors that are present in the bladder, so particularly the muscarinic receptor and the beta-3 on the bladder muscle wall itself, and also thinking about the alpha receptor in the internal sphincter in men. And that just helps us think about where we're directing our drug management. And also to bear in mind that antimuscarinic drugs can be helpful for managing some bladder symptoms like bladder spasms or overactive bladder, but they can also give unwanted side effects, such as amitriptyline causing things like urinary retention. And they're my references. And that's it. Thank you very much.